as wonderful as it is to see the Department of Health recognizing the value of supportive housing and trying to figure out how that we can use Medicaid, how we can pair Medicaid savings that supportive housing is with Medicaid spending. I mean, the fact is that if you have, we've always talked about all the money that we save the taxpayer in supportive housing, and that's true. I mean, we reduce inpatient and emergency room usage of formerly chronically homeless people with various disabilities and chronic illnesses. We reduce it by 40 to 60% when they're placed into supportive housing. The fact is, though, that that savings is often difficult to capture. The money's being spent over here, and then there's savings over there, and it's always been a little bit difficult for the Division of Budget to wrap their hands around this. And so now, finally, we're seeing that we're investing money from the same pot that we're going to save money. And so my hope is that it's going to be impossible for a Division of Budget director not to keep spending money, and it will create almost as if you are a high-cost Medicaid user, it's almost as if you will have a right to housing, because you'd be stupid not to do it. Am I overstating it, Jason?
I really do think, and I think sometimes underappreciated, is the value of the global spending cap in Medicaid and how it is such a change in how we think about and how we manage the program. Historically, Medicaid was not considered sort of a single program managed as such, where you could weigh the pros and cons of an investment over here in terms of its impact in other parts of the program. It was really a whole series of line item appropriations where people would look to make trims or modifications in those, and there really wasn't much discussion about what impact those changes would have elsewhere in the program. So now, as we look at least within the DOH control portion of Medicaid, which is the vast majority, more than 80%, we now are looking at it holistically. And we have the opportunity, and some now with discretion given to the agencies by the legislature, the ability to think differently, to think about how targeted investments in things like supportive housing can actually lower costs or help us control costs more broadly in the program. And that is really a significant fundamental shift. But we still have more work to do there. I mean, Mike and I have had the conversation about the fact that right now there are still expenses, very expensive programs, elements of providing services to the populations we're talking about here that are outside the cap, that are budgeted in the same old-fashioned way, that as budget dollars are reduced there, we aren't able to reinvest those dollars back into the system. So we have people in institutions. We want to get them out of those institutions. We want to be able to, but in order to do that, we need more community-based support and more community-based options. And so we're constantly looking at ways that we, and potentially the waiver may be a further vehicle for this, ways for us to potentially expand our horizons even further, to think about how, when we make smart strategic investments in certain parts of the program, that, or on certain elements of services to this population, we can save more than that investment in other areas. And I think that's, to me, above and beyond the $75 million, that to me is really the fundamental shift in our thinking that is what is, I think, most exciting today.
Thanks. Commissioner Hogan, we're going to be talking, we're talking about people that are similar to the people we serve now. People with mental illness, often substance abuse, have some chronic illnesses often, and they've been expensive recipients of Medicaid. We've always identified them through their homelessness, and now we're talking about, well, you know, we're looking at the highest cost users. I know that as we have shown success, every time supportive housing has success with the population, they say, well, here, we're gonna target that population even more, and we're gonna go homeless, oh, we're gonna go chronic homeless, and we're gonna get more and more challenging populations. And so we've risen to that challenge, but it's becoming more and more difficult. Are we going to have enough resources to serve this population? We're not sure what their needs are going to be, how they might differ, and we're worried about, you know, things like rates and so on.
Well, you got to be worried about that. You know, we've sort of been hit a wall on our ability to sort of update our supported housing rates to fair market value, but I view this as a bump in the road. And having said that, I want to go back and reinforce something that Jason said and add something else to that. In addition to seeing this globally, we've got to budget for it and manage it globally. And so the downside, it is unquestionably true that when somebody's life has been turned around, whether it's from institutional life or street life with a lot of expensive, ER and detox and psych and medical expenses, and as we know, I mean, $1 Million Murray, et cetera, et cetera, et cetera, we know that spending for short-term acute services that don't solve the underlying problem can be absolutely huge. So when we get somebody stably housed with the right support services, their expenditures go down very significantly. But the trouble is there's somebody else who's going through the tolls just the way they were, So we've solved the problem with this individual, but the global costs continue to rise because there are new people coming into the system who don't have that. And anybody who would think that the way to solve that is just, for example, just to give everybody an apartment and then the problem will be solved, that we're not going to get there. So we've got to figure out some way to translate the global cap and the new flexibility to make these unprecedented investments from medical care into housing to make that work. And what that means for us in mental health, as people know, is that we've sort of got to put the mental health budget under management. And we've got to have it be, globally capitated. We've got to set the contracts right so that there's no creaming. Insurance companies aren't skimming too much of the money, but so they're accountable for making this work at a global level by making sure that the people who need the support services are getting them and getting them in a flexible fashion. And then, as Jason said, to take some resources that have been outside of all this, for example, the state psychiatric centers, and we still have 24 of them. The state in the nation that has the second highest number has half as many as we do. We have a land war every time we try to close one. I can show you the scars on my back from stuff that we're going through. And we've got to reframe that from investments in communities that make the right sense and gradually move those state hospitals into that managed care framework. Do it gradually so we don't screw it up. Pay attention to the employees. Their concerns are legitimate. Not that everybody's guaranteed a job for life, but we have some obligation, if they can deliver a valuable service, to think about their careers as well. So the other thing that I want to mention that the governor has directed us to do, New York has never had a statewide plan that works across all these and other agencies, for example, OPWDD, to bring the state in alignment with Olmstead, the federal court decision that essentially says if people are in an institution and they're able to live in the community on the best medical judgment of the people taking care of them, they are entitled to move to the community. Not necessarily tomorrow, but that the state has to have an approach to getting that done. So the governor has said to us, I want you to come up with a plan to bring New York State in alignment with Olmstead. As a matter of fact, you'll see, I think, within the next couple of weeks, an announcement of several hearings or forums that will be conducted around the state where these state agencies are going to come forward and make commitments to reducing institutional capacity by substituting for it better community care. And those commitments are going to have, some hard numbers in them, which is going to be a great advocacy tool to hold the state and to hold the legislature accountable. So, as always, Ted, it's sort of a meandering approach. But the bottom line is we've got to manage this in an integrated way. It does have to be managed. It can't be just run the service, fee for service, run the cash register. And by making the link of moving into management and fusing a commitment to housing with the need for health care, at least it's possible for us to get this done.